All right, it's 4:03 Eastern Standard. I promised I'd kick off, so I'm going to get started. Again, for any of you who joined at this last minute, my name is Sarah DeSilvi. I'm the Director of Terminology for Gravity, and it's great to have you all here. This is our February 20th New Domains Terminology Public Call, and we're ready to get started. So next slide. Thanks for joining again. We mute folks upon entry, but we are a small enough group now with our work that we have lots of open conversation. So you can feel free to unmute yourself and ask questions. The calls are always recorded and available on the Confluence after the call. And we use the chat feature pretty significantly throughout our work. And just make sure you send your chats to everybody. And just a caution, if anyone sends anything to me, I'm so habituated to reading things out loud that I'm likely to read it out loud. So if you intended it just for me, it's best to save it till later. Next slide. We are a data standards development entity, and so therefore we're required to follow antitrust practices in our work. So every participant in the work has the responsibility to comply fully with federal and state antitrust laws. And this just means individuals speaking or providing written communications in this space need to refrain from any discussions that may provide the basis for an inference that they have agreed to take on any action relating to prices, services, production, and allocation of markets, or any other matter having a market effect. And we apply those concepts pretty liberally. So anything that construed as in breach of antitrust practices is a concern. So this is just the requirement of being an open standards initiative. Next slide. This is our agenda for the day. We're going to go through some brief announcements. We have a few like terminology, methods, and purpose level set slides to make, just kind of thinking about process and making sure that we ground in it. Then we're going to briefly highlight the all spring 2025 topics and goals. Dr. Nadine Burke-Harris is here, but Dr. Makai Owen is coming also as well. And at the bottom of the hour, so 4:30 Eastern Standard, 1:30 Pacific, we're going to flip to have a focused conversation on toxic stress, adverse child experiences in the California use case. Again, a lot of the work we do at Gravity is driven by specific use cases highlighting needs for terminology. We really want to make sure we're responding to real life needs in the ecosystem, and this is certainly one. We're then going to go into some of the findings from our subject matter expert gatherings regarding person level discrimination from this week, and then close just on topics in collective consciousness and action. We didn't get to that very well at our last meeting. We ran over time, so we're going to try to get to that as we go forward. Any questions on the agenda? All right, let me just see if I'm missing anything. Do not think so. And as you can see, Sarah Bahal, the amazing Sarah Bahal, is adding links into the chat for everyone to follow along. Next slide. Next slide. So this is the announcements page. Terminology Workstream is doing something different, and I've said this verbally last call, but I'm going to call it out very plainly now in every meeting going forward. We used to only meet every other week, and now because we are doing two different concurrent areas of work, we are meeting weekly. One meeting, this meeting, every other week focuses on developing new domain data standards and value sets. Again, from the start to finish, new domain identification, end-to-end review, consensus vote. And then another meeting focuses on enhancing the terminology we built in prior cycles. This includes building program classifications or leaning into gaps in food insecurity or housing concepts. And so we meet weekly, we just alternate topics, and you are in the new domains call where we're doing that start to finish assessment of necessary language to tell critical stories for domain topics. Technical Workstream meets Wednesdays, 1 to 2 Eastern Standard Time. You're welcome to join that as well. Implementation Workstream meets quarterly now, and it's the last Thursday of February, May, August, and November. The November one is not on Thanksgiving, and so we're going to shift it to the week prior. Thanks, Mark, for calling that out. And then that's coming up very shortly, and then we're going to be at HIMSS. Vanessa Candelora and Corey Smith, my partner in the good, who's the technical director, will be at HIMSS shortly. So hoping to see you all there. Any questions on this? Okay, next slide. Next slide. I wanted to one of our principles is accountability. I see Greg on the call. Greg, you were instrumental, and Mark, you were all instrumental in helping create our data principles. So the last time we presented this at the last meeting, instantaneously, we had all of you reflect on opportunities to improve our vision, but this is the Gravity vision, and we're having a strategic session shortly, so looking to reflect on this, but the Gravity Project's striving to create a world where health and social care organizations readily share information needed to effectively meet the social needs of individuals, advance health equity, and improve health outcomes in communities. And in italics is part of the language that you all leaned into by using standard terminology and technology. And so I note that we're accountable to it. It's highlighted. It's already been added to the strategic session for consideration, and we thank you all. Some of the opportunities we're using standardized and leaning into what standard technology means more deeply. So just know we heard you and are accountable to it. Next slide. This is the lexicon that grounds what we do because we are really looking at the breadth of it in this cycle by finally into protective factors. It's appropriate to come back to it. So health equity is a state in which everyone has a fair and just opportunity to attain their highest level of health. Social determinants of health are the conditions in which people are born, grow, live, work, and age, and they're shaped by the distribution of money, power, and resources. Social determinants can offer both positive and negative forces, and this is critical, again, for the work that we're doing. Protective factors are the characteristics or strengths of individuals, families, communities, or societies that act to mitigate risk and promote positive well-being and healthy development. We are naming these with intention in this cycle. Negative forces are social risks, which are adverse social conditions associated with poor health. These are also known as health-related social needs. There's very equivalent. And then social needs are patient-prioritized social risks. And again, you can see there's population level and person level concepts within this. Next slide. We're very grateful for our members, sponsors, and partners. We are a collective in the truest sense of the word. So everyone helps do the work that we do. We're the only accelerator, though, that kind of breaks the member sponsor model completely by designating roles for designated members that are critical from our work from a social justice framework. So patients, community-based organizations, entities that usually would not be at the table, we create a space for them, and are very grateful that they're part of our work. And many in-kind supports too, just incredibly grateful. Next slide. This is our 2025 roadmap. I'm going to keep on highlighting it throughout, I think, because it's such a high level view. You can see in the spring, everything in dark green is kind of that new domain work. We're doing 3 domains a cycle now. So we're addressing protective factors, person level, racism, and toxic stress within our new domain work in this meeting. And then you can see that enhancements work is light green. So developing HCPCS terminology for food as medicine concepts, establishing standards for documenting enrollment, developing an open classification of social care programs. That's all enhancement work happening in the other meeting. And in the fall, we're planning for new domain work in food access, neighborhood safety, and one of the 5 topics in environment we're going to be covering. We just need to define which one, so working on that with members. Our technical work stream is working on preparing for the STU 3 and exploring new use cases with our operating committee. Again, everything that we do is informed by our members, so that's happening. And then, of course, the implementation affinity group is carrying along as we, with our implementation highlighting implementations such as like the state of New York and entities like that. I just want to make sure if, oh, look, Hi, Makai. He's here. I'm just making sure that I saw that you were here. So I'm gonna quickly go through these next slides and we'll get to you shortly. Again, want to center the California guests when we can. Next slide. So one thing to note is that all work within Gravity is prioritized for the roadmap by Gravity governance members. This is important to say. Those members, including designated members, vote literally on what goes on the roadmap, every new domain and use case, and this work is truly a collective representative of the voted upon priorities of the whole body and not just one entity. So that is, we are consensus based and collective, and even in what makes it onto the roadmap. There's no one funder that drives any one part of what we do. Next slide. And these are the data principles I mentioned before. They are really critical for what we're doing. We operate from social justice and data justice frameworks. So these principles were part of our founding and they carry through what we're doing. They include improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and very significantly and importantly, preventing, reducing, and remediating harm. The last one means that we operate from an understanding that the data that we are generating can be used for the good, but it also can put people at risk. And so we consider that very carefully as we are doing the work. Next slide. I'm just going to check in with Makai. Makai, do you need to go now, or are you okay waiting for a few minutes?
I'm okay.
Oh, great. Hi. Okay. I'm going to carry through. I think I have it perfectly timed to center you at 1:30 Pacific. Okay. Next slide. Any questions on what I just mentioned? Okay. All right. So then one of the things that we wanted to just level set on also is just, so again, we have a brief overview of Gravity, a half an hour presentation on California. It's going to be perfect. I gotcha, Dr. Burkaris. I think I gotcha. So before we kick off the California use case and ACEs, perfect. Okay, we're going to be okay. I think there's some people that need to leave. I'll try to make this as brief as possible. Next slide. We're going to go through just some level set slides about reflecting on some of the questions that we raised last time and bringing them back. This is a quote that I came across this week that seemed incredibly timely. Toni Morrison's quote, "Definitions belong to the definers and not the defined." So in our last meeting, we were asked to frame how different types of expertise and experience are valued in a space working towards codes, because it can seem very abstract. It's important to note that Gravity Terminology team operates from models of care, nursing models, social work models that recognize knowledge and wisdom in all of its forms, and that the role of professionals here is to facilitate the knowledge of everyone towards wellness. So the work is no different here. All knowledge is valued. The work of our terminology team and the community is to listen well and help craft language. To represent this knowledge within the structure of taxonomies to tell critical stories. The data part we'll try to finesse, but all types of knowledge, lived experience, different types of expertise, it's all of value to do the work that we do. And just noting that from a social justice perspective, part of what it means to develop language in this space, and just thinking about Toni Morrison's quote, is fundamentally ensuring we center voices in data making that historically have not been centered because their knowledge is critical. I want to hold space for a second and give space to my colleague Asha just to reflect, because I called her in at the last meeting and it was unexpected. So I'm going to call her in again with a little more preparation. Asha, if you can just share a little bit, that'd be great.
Sure. Thank you, Sarah, for giving me the space to address it. So why do data stories matter? And why is it critical to include the voices of those who are closest to the problem? That's what I want to talk very briefly about. And just say, in my experience, I was a labor and delivery nurse for 20 years, and I had the honor of witnessing thousands of births. I worked at a birthing hospital that does about 20,000 deliveries in a year. So we saw a lot of births. And I will tell you, in that moment of birth, you see the creative force of God, right? It's humbling, awe-inspiring, and reminds us of what is at stake in this moment. But alongside that beauty, I also saw the maternal health crisis unfold in real time before me. And the crisis was shaped by delays, denials, and disrespectful care impacting mothers. But the problem is it impacted all mothers, but the problem is especially acute for Black and Native American mothers. So regardless of income or education, Black and Native American mothers faced unequal treatment. And this wasn't anecdotal in my experience. It was a pattern that I observed in practice at the bedside over 20 years. And it signaled that the disparities were not about individual behaviors, but about systems. We often say it's not race that is the risk factor in maternal health equity spaces, but it's racism that is the factor of note. Racism is an adverse event, and just like hemorrhage or an acute hypertension effort, those things, it's an adverse event, but unlike those things, we've never had terminology to track it in medical encounters, right? So as a maternal child community health nurse specialist at the Center for Black Women's Wellness, we have led the Atlanta Healthy Start initiative for 20 years. And I work to bridge community and clinical integration by expanding access to community-based maternal safety bundles. But in my experience, serving on the Georgia Maternal Mortality Review Committee for 4 years before it was disbanded last fall, it reinforced for me how difficult it is to identify racism in maternal deaths. And we would spend a lot of time debating and deliberating, reading between the lines to find the thread that would identify if racism, discrimination, or bias factored into the outcome. And this is where I came to the point where terminology or nomenclature, these are not just words. They shape interventions, they shape policies, they shape systems themselves. So language shapes care. And if we don't name it, we can't measure it. And if we can't measure it, we can't fix it. So these historical, environmental, and community context has to be embedded in the standards to reflect the lived realities of community. And so I would say I see data stories as a tool of justice. I am a descendant of enslaved individuals. I am the great-granddaughter of a lynching victim and the granddaughter of the Great Migration. My family stories, like so many others, is one of resilience and survival. But our data stories must reflect those realities and include the voices of those who are closest to the problem, whether or not we have health information technology knowledge or know-how. So by creating the language, we don't just collect data. We build a foundation for equity, safety, and justice. And that's why data stories matter. They determine who gets seen, who gets heard, and ultimately who gets to live. So I wanted to share that as an example of why data stories matter and why it matters who's in the room while we're crafting the data stories. Thank you, Sarah, for allowing me to share.
Thank you, Asha, for being back with us. Thank you for being such an amazing advocate. And I love you.
Right back at you.
Okay. Okay. Any other thoughts before we move on? Oh, yes. Yeah. Thank you, Mark. Thank you. I just want to note, it was our friend, Kenyatta, partly, and Kenyatta's in and out today because she's on the phone, but it was the brilliant Kenyatta Jackson who asked that question last time, and it was worthy of bringing back. So thank you for asking it. Okay, next slide. I want to note too that and we've come across this, and again, I'm going to get you there on time, Makai. I promise. Not that you're watching it, but part of telling critical stories also means reviewing published literature and methods represented in science, and noting absences in instruments, absences in processes. That's also fundamentally part of the work we're doing now. Existing evidence is built on structures of power that have historically missed centering voices of most affected people, patients, communities. And elevating missing perspectives is a fundamental part of the models of knowledge that anchor our work. So we can address absences and concepts easily. This is what we do. We identify what needs to be said, and we say it, and we create language for it. Addressing absences in instruments is a many-year process within the evidence of psychometrics. So what we do here is name them, and we can see this happening as we're doing our work. And we're going to talk a little bit about this later on, but we review instruments that exist, and we consistently name instruments that are missing. We did this with incarceration. We did this within language access. We did this within digital literacy. We consistently over and over again identify instruments that are not there. And so we're just anticipating this is what we're doing again. Lucy?
Yeah, Sarah, another editorial possibility for future slides. In the second bullet, the second line, structures of power that have historically missed centering. I think what's really has been going on is that those voices have been repressed.
Correct.
They're not just missing. And so structures of power that have historically repressed the voices most affected, I think would be more accurate there.
That's correct. Thank you so much, Lucy, for calling that to light. All right, I'm trying to get through to stay on schedule, and there's a couple more slides. So one more slide or two, I think. I just want to note that as we go in, this is a consistent theme too. Another thing that is like part of our work, but it is within and without of the work, is just we often have conversations about best practices for screening for social risk. And we have this on whether screening should even happen. And we have it by domain. And there's emerging evidence on risk benefit depending on the domain of reference. If you look in like UST, PSF, United States Preventive Service Task Force recommendations, different social risks have different ranking, and there's different population focuses. What we note is there's policy and regulatory drivers that define screening processes, including population and frequency. This often happens in advance of consensus on process, but we learn a lot from them. These include waivers, quality measures, state and federal programs and initiatives, and we're going to hear about one of those right now. And so there might be differencing, and this is Makai, you have taught me so much in my short time with you. I want to thank you. I didn't know there were such differences in opinions on process. It's not our job to standardize that. We often discuss best practices regarding that. Our job is to create data standards to support processes in screening or not create them. If our SMEs determine the risk of screening and identification and standardized instruments is too great, and this is what we did with incarceration status. And I say that here only because we're going to be hearing, like, as we had this conversation sometimes in our SME meetings, and we have these conversations here, and so we might hear like specific programs like the New York waiver that has a specific process with a specific instrument and a specific frequency. Our job is to enable that, whatever process they're defining with data, but also have the conversations about best practices when we can. And I believe that's the last, and I think 427, next slide. Yes, this is just what we're doing here at Gravity, identifying standard instruments used to identify the domain, establishing core diagnoses that need to be stated, identifying person-centered goals related to the risk and condition, and thinking about the things we do to address the risk or condition, and defining that in terminology as well. So that was the terminology level set, and again, trying to highlight like how we operate, what knowledge we center, which is all knowledge, how we weigh evidence with what exists and what's missing, and how we work within the different lenses of our focus, where our focus is developing language and we talk about process, and we even write policy statements on process, but solving process is not within the scope of our work. And now, I believe, Makai, are you sharing slides?
Yeah, I'm happy to.
Awesome. And so I'm going to let Makai and Dr. Nadine Burke-Harris come to present on one of our domains today, which is of this series, which is toxic stress, and the California use case. And so honored. And you guys can take a moment to introduce yourselves to the community before you kick in so that we can all understand who we are lucky to be with today.
Sure, I'll get started. So my name is Makai Owen. I am a pediatrician based in Sacramento. Clinically, I take care of kids who are incarcerated, and I am a co-principal investigator for the UCLA UCSF ACEs Aware Family Resilience Network, also known as UCAN. And UCAN administers the ACEs Aware initiative on behalf of the California Department of Healthcare Services and California Office of the Surgeon General, which I'll talk about there. And I will pass it over to Dr. Burke-Harris for a quick introduction.
Hi, I'm Nadine Burke-Harris. I'm a pediatrician and a researcher and an advocate. I was the founder and CEO of the Center for Youth Wellness in San Francisco before leaving to join state service as California's first Surgeon General. And I served in that role from 2019 to 2022. And now I serve as a senior advisor to the ACE Resource Network.
All right, thank you. So I am going to talk about California's model of an evidence-based approach to addressing ACEs and toxic stress, the ACEs Aware Initiative. And I'm going to start by giving some background on ACEs, the term, some of the evidence around the impact of ACEs on health outcomes and social well-being outcomes, and then talk about California's approach to ACE screening and response. And I'm going to start by defining some terms. So in the context of this talk, when we're talking about adverse childhood experiences, we're really using that term to recognize the term ACEs that comes from the landmark 1998 study that was conducted among 17,000 adult patients by CDC and Kaiser. And in that study, they kind of categorized ACEs as these 10 categories of childhood adversities in these 3 domains experienced before the age of 18. So our domains are abuse, neglect, household challenges. We have physical abuse, emotional abuse, sexual abuse, emotional neglect, and physical neglect. And then household challenges such as having a caregiver, someone in the household, mental illness, witnessing intimate partner violence, parental separation or divorce, incarceration or substance use and substance dependence. And kind of as we go throughout the talk today, we'll recognize that, of course, these are not the only forms of childhood adversity. And then recognize also with the Kaiser CDC study that the study population was primarily Caucasian individuals, primarily high school graduates, and many with college. So not representative of the diverse population that we have in California, the diverse population in the United States. And we will recognize that and how we kind of contextualize that as we go through this conversation today. In terms of the prevalence of ACEs, they're very common. This is from the California Health Interview Study, the CHIS study, which was done in most recently in 2021. And we found that in California, at least about 72% of California adults experienced at least one ACE, and about 20% experience 4 or more. And so why that 4 or more is so important is that we know that across many different populations, now well beyond the original Kaiser CDC study, that there is a dose-response relationship between exposure to ACEs and a number of poor health outcomes, physical health outcomes, mental health outcomes, and social outcomes. So I'm going to go through these next examples of this really quickly. And as I go through these examples, I'm not in our time today here to focus on kind of the epidemiology of the ACEs or any of these particular conditions necessarily. But what I want to kind of the group to focus on today is the wide range of health and social conditions that are associated with ACEs and have that dose response relationship between exposure to ACEs and development of a poor outcome, because I think that really is the foundation of ACEs awareness approach. So this slide here shows that the leading causes of death in the United States in 2022 and the odds ratios for exposure to 4 or more ACEs. And so we can see that the odds ratios for things like heart disease, cancers, for unintentional injuries are all double, same for stroke, significantly higher for chronic lower respiratory disease, Alzheimer's disease, diabetes, liver disease, kidney disease. So across all these top 10, we see that dose response relationship. And in addition to those top 10 cases and that physical health, we know that there are strong associations between exposure to ACEs and a host of poor mental health outcomes, whether it be mood disorders, anxiety disorders, substance use, impulse control disorders. So again, what we're noting as we go through here is the dose response relationship. So as our exposure to ACEs increases, so does the prevalence of these poor outcomes. In addition to that, there's a host of others that we could include, but I wanted to share a couple. So ACEs and reproductive and sexual health conditions. So, studies show that if you have 5 or more ACEs, you have almost 2.5 times the likelihood of unintended pregnancy, 4 times the likelihood of teen pregnancy, 7.5 times the likelihood of violence and victimization, even 3 times the likelihood of chronic pelvic pain. In addition, ACEs obstetrical conditions. So again, we see these relationships hold in many different populations. I wanted to share some data from a recent CDC study that came out that was very relevant to my practice, given that I take care of adolescents. But it was the first study that looked at high school students today, really. So many studies of ACEs kind of interview adults and have them reflect on their exposure to ACEs during childhood and the development of poor physical, mental health, or social outcomes later in life. But this study was unique because it looked at both the prevalence of ACEs among high school students in the United States today, and it looked at various physical, mental health, and social conditions experienced by the high school students. And a couple of things really stand out in the study. So one, the prevalence was significantly higher than many previous studies had showed before. So for females, it showed that about a quarter of high school females had experienced 4 or more ACEs, and only 18% had experienced 0. And number was lower for males, but still significantly higher than previous studies, with 13% experiencing 4 or more ACEs. And so in this study, they looked at population attributable fractions for health conditions or risk behaviors among high school students. So it may be difficult to see on your screen here, but what the study looked at is these various health conditions or risk behaviors and how much of those were attributable to ACEs. So if you were to remove ACEs from this population, what percentage of these conditions would you also eliminate? And so some things that really stick out to this is that almost 90% of cases of attempted suicide in adolescents and high school students was attributable to ACEs. 85% of even seriously considering suicide was attributable to ACEs. 65% of persistent feelings of sadness or hopelessness was attributable to ACEs. And almost 85% of current prescription opioid misuse was also attributable to ACEs. And so recognizing that we are in the midst of a youth mental health crisis in this country, I just thought it was really striking to see these population attributable fractions and understanding that in high school students today, that exposure to these 10 adversities, even though they're a limited evaluation of the total number of adversities or different types of adversities that children and adolescents and youth can experience, that even these 10 ACEs are really driving a lot of what we see in terms of mental health issues, suicide, sadness or hopelessness, opioid use, binge drinking, alcohol use. And like I said, I practice in a juvenile detention setting, so wouldn't be remiss to not share some of the data there. But again, this is from a systematic review, which also showed a dose-response relationship between exposure to ACEs and involvement with the youth legal system. So as children were more likely to be exposed to ACEs, they were also more likely to be involved in the youth legal system, and that likelihood increased with each additional ACE exposure. And so this was just like a summary of some of the different medical conditions that are associated with ACEs. I think historically, a lot of people have focused on the mental, behavioral health, and substance use outcomes related to exposure to ACEs. But one of the things that we focus on in ACEs Aware is recognizing those and recognizing that they're very important, but also recognizing that there's also serious physical health consequences, and that exposure to ACEs through toxic stress physiology can impact our neurological system, our endocrine metabolic systems, and our immune systems, which, excuse me, I'll talk about a little bit more as we go along. And then finally, one more piece of data that I wanted to share with this group, just really important as we think about the context of the work that is happening in California, is a recent CDC study that showed the annual cost of ACEs in the United States. And their estimate found that ACEs cost the United States $14.2 trillion annually. And in California, that number was about $1.5 trillion annually in California alone. And so much of that is in years of productive life lost, but also 292 billion in additional healthcare utilization and expenditures. So to summarize that, I think what I wanted to demonstrate by sharing that data is that when we look at the 10 ACEs that we're referring to at the beginning, that there is just so much data that shows a dose-response relationship between these particular ACEs and poor outcomes later in life. And there's a growing set of literature that is showing the impact of those ACEs in terms of healthcare costs and utilization and loss of productivity, that allow a lot of research to be able to be done not just on health outcomes, but also on utilization as well. And I'm going to transition now to kind of talking about the mechanism through which ACEs can lead to numerous poor health outcomes, physical health, social, and mental health. And I think when we think about that, it's important to, again, to note that these odds ratios are increased along a whole range of medical conditions. And so the mechanism through which that can occur is through the toxic stress response. And so start by defining that. So toxic stress can be defined as prolonged activation of the stress response system that can disrupt the development of brain architecture and other organ systems and increase the risk for stress-related disease and cognitive impairment well into adulthood. And I'm not going to talk much about this today, but it is important to recognize that not all stress and not all adversity can kind of lead to that toxic stress physiology. There's positive stress that can be mild or moderate, and is helpful in terms of healthy development. Tolerable stress may be more severe response, but limited duration. But when we're talking about toxic stress physiology, really focusing on that extreme, frequent, or extended activation of the body's stress response, which can result in neurologic, endocrine, and immune system disruption. And so this is an oversimplification of what that toxic stress physiology looks like, but I really love this graphic, and I think it provides a great summary of kind of the foundation, the scientific foundation for ACEs Aware. So we have early life adversity here at the top, and we think about ACEs and other adversities as external stressors. And that early life adversity, in the absence of sufficient protective factors, or in the combination of some predisposing vulnerability, can lead to chronic dysregulation of the stress response system. And that chronic dysregulation can have, deleterious impacts on our neurological system, on our immune system, and in our endocrine system, and also our genetic regulatory mechanisms, which can cause a whole host of other medical conditions. So it's this physiology that leads to so many of the bad outcomes that we talked about earlier in this talk. And so I'm not going to focus too much on this here, but this is just a table of the biological systems that are disrupted by toxic stress. There is a lot of science and a lot of studies that show the mechanisms through which toxic stress can impact our neurological system, our immunologic system, endocrine system, genetic regulatory mechanisms, and the health impacts that can have. And we see those health impacts in the ACE-associated health conditions that we reviewed earlier. So for ACEs aware, the purpose of ACE screening is to determine a patient's clinical risk for toxic stress. So ACEs aware is really built on the recognition that there today isn't a biomarker that is available to identify the risk of toxic stress. And so we're using ACE screening, and we'll talk about how later, to really approximate or determine a patient's clinical risk for toxic stress, which will help us to guide appropriately tailored treatment and a follow-up plan. And so I think that for sometimes that can be a complicated way of trying to communicate what we're doing. And so for me, the best way to describe it is I work at juvenile hall, and a common clinical picture for me might be an adolescent that comes in that has hypertension or elevated blood pressure, obesity, asthma, maybe some skin issues, and then a whole host of mental health and behavioral health issues. And so that could be rule out schizophrenia, rule out schizoaffective disorder, rule out bipolar disorder, depression or anxiety. And for many of the young people that I take care of, that they have, by the time they come into juvenile hall, they may be on 5 or 6 different medications. And each one of them is treating a different condition. And so I think for ACEs aware, the idea is that for many children, many adults impacted by toxic stress, that historically we have been treating the symptoms of toxic stress, and we continue to treat the symptoms of toxic stress, but we are not treating the underlying physiology. And until we are able to treat the underlying physiology, that we will not be able to improve those health outcomes and ultimately achieve health equity. And
Okay.
so,
Can I add just one tiny thing?
absolutely.
So, one of the things that it's really important to understand about the development of the toxic stress response when you have this repeated activation of the biological stress response that then that makes it difficult for the stress response to be able to shut itself off. So you have this dysregulated stress response. And one of the things that is really key about that is that children's brains and bodies are just developing. So high doses of adversity in childhood affects the developmental trajectory of our neuroendocrine, immune, and genetic regulatory systems, right? So that developmental component is so key because when you have, for example, if you have the same level of stress in an adult who didn't have adversity in their childhood, right? The level of risk is different than when you have a child's developing brain that is then developing in the context of these high levels of stress hormones that impair executive functioning, that activate hypervigilance, all of these different things. And so recognizing that a dysregulated stress response affects the developmental trajectory of not only children's brains, but their immune systems, their hormonal systems, and even the way their DNA is read and transcribed. So that is part of the rationale behind ACE screening, because there is a strong body of data that shows that early detection and early intervention improves outcomes.
Thanks, Dr. Burke-Harris. And so I think, again, wanted to pause here or reorient here for a second to recognize that for us, the purpose of ACE screening is really to determine a patient's clinical risk of toxic stress. And when it comes to ACE screening, our recommendation is that thinking about ACE screening is kind of a triad. So a complete ACE screening in the context of ACEs Aware's recommendation is understanding a patient's exposure to adversity as indicated by an ACE score, the clinical manifestations of toxic stress, if the presence or absence of ACE-associated health conditions, and the presence of protective factors. And I'll talk a little bit more in a second about what that means, but I want to kind of, before I do that, kind of address some common questions that ACEs Aware gets on its model. And I think the first is, why include only the 10 ACE categories in the ACE score? So a common question may be, well, what about community violence? What about bullying, exposure to racism and discrimination? And for us, I think the answer is that we recognize that they're very likely to be risk factors for toxic stress, but they haven't been studied yet into the same degree as the 10 ACE categories that we described earlier, such that there's validated odds ratios that are available in large population-based studies that use the 10 standardized ACE criteria, and that the strengths and association between other experiences, such as community violence or racism, and health outcomes have not been similarly standardized. So we recognize that there are additional risk factors for toxic stress, but the kind of odds ratios and the data behind them have not yet risen to the level of the 10 ACE categories. And so when we think about what are other risk factors for toxic stress, just defining what we mean there is circumstances, exposures, or conditions or resources that increase the likelihood or susceptibility of the development of the toxic stress response. And I think there's a subtlety here that is really important to point out, which is, for example, exposure to community violence or experiencing community violence or experiencing structural or interpersonal racism, that they can directly impact our health in many ways that may not work through the toxic stress response. And one of the things that we're really focused on here is the mechanism of toxic stress physiology. So for many factors, they may be associated with a number of poor health outcomes across different populations. But there may be direct effects that are not through toxic stress physiology, as well as impacts that may be through toxic stress physiology. And when we think about other risk factors, some of the risk factors we think about are community or school violence, discrimination, housing instability, food insecurity, separation from a caregiver for a host of reasons, living with someone with serious physical illness or disability, or having a parent or caregiver who died. And there's a whole host of other ones that I'm sure we could consider, but more research is needed to understand how those may impact the risk of various physical, mental, and behavioral health outcomes, and whether or not they work through the toxic stress response. And in addition to that, it's important to understand kind of the intersection between the social determinants of health, between ACEs and toxic stress. And we know that the social determinants or social drivers of health can foster unmet social needs that often co-occur with ACEs, that the social drivers of health can contribute to the prevalence of ACEs, but also exacerbate their impact. And they can directly lead to toxic stress, or they can compound cumulative dose of adversity. And so ACEs Aware doesn't necessarily recommend a formal social determinants of health screen or screening for other risk factors necessarily in the same way as we recommend ACE screening. But we do recognize the interplay between all of these and have quite a bit of clinical recommendations on how screening clinicians may consider the social drivers of health and other risk factors of toxic stress. And of course, want to mention ACEs and health disparities. And so we know that ACEs affect all communities, but there are significant differences in prevalence and outcomes and burdens in people who are women, low income, LGBTQ, Black, Latinx, Indigenous people, and other people of color. So we understand and recognize that significant disparities exist, and also recognize the structural inequities that contribute to these differences and disparities. And then lastly, wanting to recognize that also there is an intergenerational transmission of toxic stress, such that historical and cultural trauma and ACEs in parents can lead to toxic stress in the parents, and that can have a whole host of impacts as well. So there's parent factors, which could be inability to conceive, epigenetic changes and stress system genes that can be passed on. There's preconception and in utero factors, such as telomere shortening and other stress dysregulation, and a host of postnatal factors, child health, the microbiome, child behaviors, the capacity of parenting and the parenting style. So in the work that we do and how we recognize kind of ACE screening in a system, recognizing kind of the interplay between historical and cultural traumas, parent ACEs, social drivers of health, the traditional ACEs and other risk factors and toxic stress physiology is absolutely a priority for the work that we do. And lastly, I want to talk a little bit about protective factors, which I won't get into in much detail, but recognizing that the balance of negative experiences, risk factors, or other ACEs, and protective factors can really have a positive or negative impact on health outcomes, and that protective factors are important to consider and think about in the context of ACE screening. And when we think about protective factors for us in the context of ACE screening, kind of defining them as circumstances, exposures, conditions, or resources that help prevent or mitigate the physical, mental, and social health impacts of toxic stress. So that can be safe, stable, and nurturing relationships, positive childhood experiences, stable housing and food security. I won't go through the whole list, but again, ACEs Aware recommends and actually requires for reimbursement an assessment of protective factors. But we don't recommend a formal screening, again, because the evidence in terms of the impact of these protective factors as a group or individually on various health outcomes is not established in the same way as it is for ACEs. I am going to skip a few and talk really quickly about the ACEs Aware initiative. And so I'm going to spend a couple minutes talking about ACEs Aware, our screening model, our screening tools, and our guidelines for clinical response. But before I do that, I want to pause for a second. Dr. Burke-Harris, I know that you have to jump off at 2, and I can stay a little bit longer. So I'm not sure if there's anything that you want to share before you jump off.
Yeah, there was just one thing that I wanted to share. Thank you so much, Makai. And I think that it's a little bit, let me see if I can share screen here. Oh, it says I'm not allowed to share. The host disabled share.
Oh, now I think you can now.
Okay, all right. So let me do this. So recognizing that we have these various exposures, the traditional ACEs and other risk factors for toxic stress that activate a biological process that puts our physical, mental, behavioral health at risk over the life course, right? And one of the things that I want to highlight that we highlighted in the California Surgeon General's report on ACEs, toxic stress, and health is that a lot of people kind of ask the question of how do we respond to this? In fact, I saw in the chat some folks, think about, well, we need to be doing preventing, right? Like we need to address the causes of these ACEs. We need to prevent these things from happening in the first place. Primary prevention, that makes a ton of sense, right? And then otherwise, we have this other piece of we need resources for families to get the services that they need. When folks have had these experiences, or if they're having mental or behavioral health consequences, they need high quality treatment. And so being in government, there was a little bit of the debate as like, where should we be putting our resources? This tertiary prevention of treatment, or this primary prevention of preventing from happening in the first place. And one of the things that's really key that I'm sure all of you are familiar with is the notion that in public health, you need to do primary, secondary, and tertiary prevention. So preventing things from happening in the first place and the underlying drivers that give rise to these conditions, yeah, we got to do that. Early detection so that we can do early intervention, that is the piece that was really missing when it comes to the public health crisis of ACEs and toxic stress. And then tertiary prevention in terms of treatment, we have some of that. And what I wanted to share, if you all can see it, is this may be a little bit counterintuitive, but I just wanted to share this piece. So this is a slide that looks at maternal mortality rate in California in the United States. And when California implemented a very intentional clinical program to reduce maternal mortality, what we see is that while we see here in red nationally, maternal mortality continued to increase, in California, we saw a reduction in maternal mortality by 55%. That looks like great data, right? Here's the thing that's really key when we talk about equity. When you have a condition where vulnerable communities are most impacted, that when you address the underlying biology, right? Like in California's maternal quality care initiative, when we reduced maternal mortality, the greatest benefit, as we see, was to Black mothers, right? Who had the disproportionate disease burden of disease and got the disproportionate benefit. And we can see the impact for our Asian and Pacific Islander, white, and Latinx moms. Similarly, when we look at the advent of antiretrovirals to treat HIV disease, we see, let me go back, we see that deaths dramatically declined with the implementation of the multi-drug cocktail for treatment of HIV. But again, when we pull that data apart and see that the communities, this top blue line is Black males, then we have Hispanic males, then we have Black females. When there is disproportionate burden of disease on certain communities, then biomedical advances to treat those diseases also help to reduce disproportionate disease and death. And part of the reason I wanted to share that, and it felt important, is just recognizing that one of the things that has vastly been missing, we have not deployed our biomedical resources and tools for treating toxic stress. And we recognize that when vulnerable communities are disproportionately impacted by toxic stress, the advancement of the treatment stands to benefit them tremendously.
Thank you. I see a bunch of questions in the chat. And Sarah, is it okay if I go for a couple more minutes just to talk about kind of our model and thinking about kind of explaining kind of the clinical interventions and some of the other social interventions? And I think many of them we will address if we go along. And I know
I
Dr.
think so, yes. And I just want to note say one thing publicly, even though I answered in the chat. In our subject matter experts on ACEs, we have all kinds of perspectives. And this is the second meeting that we're having. So we're just looking forward to having this conversation as we go forward. And Dr. Burke-Harris, thank you so much for coming.
Yeah, thank you so much.
All right, Makai, you keep going, and then I think we have a couple more minutes, and it may be a couple more minutes for questions after, and then we'll switch to the next topic of the night.
Sure. So I'm going to talk about the ACEs Aware model and try to address some of the questions I saw in the chat. And so ACEs Aware is a first-in-the-nation effort to promote early detection and intervention to mitigate the health and societal impacts of toxic stress. It was launched in 2019. And since launch, we have screened over 1.5 million individuals and have conducted over 3 million ACE screens. And over 45,000 people have completed our training, our core training. To be reimbursed for ACE screening in California, you have to complete the Becoming ACEs Aware in California core training. And I'd also like to add that ACEs Aware, kind of before the launch, California did a CalQuick study, which was an ACE screening and response pilot that was done across the state in many, many different clinics. And the results of that pilot found that ACE screening was deemed feasible, acceptable, and beneficial by both clinicians and caregivers. And also, there was no documented harms in ACE screening immediately and then 6 months after the screen. So it was a very rigorous pilot that was conducted to kind of address some of the common concerns around ACE screening. These are the goals of the initiative, which is to raise awareness, to facilitate practice change. And there has been significant investment here in developing trauma-informed networks of care, which I won't have time to talk to today. And again, in terms of what's happening in California, ACE screening is often focused on, but I do want to point out that it really is just the top of the pyramid, and there is funding for toxic stress research. There's funding to develop trauma-informed networks of care. There's tens of millions of dollars invested in cross-sector training and collaboration, public awareness and education, and some health equity policy changes, some of which I'll talk about today. So ACEs Aware offers Medi-Cal providers training, screening tools, clinical protocols. And as of 2020, eligible Medi-Cal providers can receive a $29 reimbursement for ACE screening. Again, I won't repeat this, but this is the purpose of ACE screening. Main point being here that we're using ACE screening as a proxy to identify risk of toxic stress. And the purpose of that is recognizing that toxic stress is a medical condition that's amenable to treatment. Intervention in children and adolescents can improve neurologic, endocrine, metabolic, and immune system development. And intervention in children and adults can improve physical, mental health, and can also prevent that intergenerational transmission of toxic stress. We recommend screening every patient without selection bias. There's payment for ACE screening for children once per year, and for adults, it's once per lifetime. Screening tools, we recommend different screening tools for children and adolescents and adults. The ACE score, again, refers to the total number of ACE categories experienced rather than the severity or frequency of any category. For children, the screening tool that we use is the Pediatric ACEs and Related Life Event Screener. This screening tool was studied and has high phase validation. It was developed by the Bay Area Research Consortium on Toxic Stress and Health, and that's a partnership between Center for Youth Wellness, UCSF, and Benioff Children's Oakland Hospital. There's 3 screening tools, one for children, one for adolescents, for the parent to fill out, and one for an adolescent self-report. So this is what the Pearl screening tool looks like. So part 1 is what's used to assess the ACE score. It is essentially the same questions, the same 10 questions, just framed a little bit differently as are in the original ACE study. And then part 2 are other risk factors for toxic stress. So community violence, experience and discrimination, issues with housing, issues with not having enough food to eat, separated from a caregiver. So some of those risk factors that we talked about earlier. And again, in our risk assessment, we only consider part 1. For part 2, a screening tool that's very similar to the ACE questionnaire that was used in the Kaiser CDC study. Also want to point out that for our risk assessment purposes, that it's not only the presence or absence of ACEs that defines risk, but it also is the presence or absence of ACE-associated health conditions. And so recognizing that there's a number of ACE-associated health conditions, and that a person who has experienced one ACE repeatedly may have toxic stress physiology and may have the downstream consequences of that. So when we get to the algorithm, I will kind of walk through how we would interpret that on ACEs Aware's model. I'm going to skip this one and just recognize that a lot of what our training does is to reach out to clinical providers and promote ACE screening, but to recognize that ACE screening starts with principles of trauma-informed care. So we never recommend that people without kind of a core understanding of ACEs and toxic stress physiology, or who haven't done any work in the principles of trauma-informed care, start screening from day one. That is why California has a training requirement in to kind of reinforce that anyone who is screening for ACEs should have some minimum working knowledge of the prevalence and the impact of ACEs, the impact of toxic stress, but also some of the best practices in communicating an ACE screen and responding in a supportive way. I'm going to skip these really quickly. And so this is our risk assessment algorithm that we train providers on who are doing an ACE screening. And so a couple of things that I want to point out here. Number one is that we are currently updating this algorithm based on emerging science in the field, but also on feedback from clinicians and patients throughout the state. We have a committee that is representative of a group of national experts on ACEs and toxic stress that is working on updating it. So a couple things that I want to highlight here is this is for a pediatric algorithm. And so we have our high risk categories. And so we deem anyone with 4 or more ACEs at high risk of toxic stress physiology, whether or not they have associated health conditions. And again, that's based on the population health data. But importantly for children, if they have an ACE score of 1 to 3, but they also have ACE-associated health conditions, we also recognize them as high risk of toxic stress physiology. Here again, with the idea being that for children and adults, people may be exposed to 1 or 2 or 3 ACEs, and that those ACEs may have been very severe, they may have been very frequent, they may have happened in a really developmentally important time in a person's life. And if so, they may be having toxic stress physiology and the impact of that. So we want to recognize them as high risk. Similar to kids in the adult algorithm, we recognize low risk, intermediate, and high risk. And here, for an adult that has an ACE score of 1 to 3, if they have associated health conditions or symptoms of toxic stress, we also consider them at intermediate risk. So I want to talk a little bit now as we end about kind of what our recommendations are in terms of a follow-up to an ACE screen. And ACEs Aware's recommendations are really that clinicians who are screening for ACEs supplement their usual care with evidence-based strategies to mitigate the toxic stress response. So if we're treating, for example, in my clinical setting, if we're kind of treating the asthma with an inhaled steroid and albuterol, and we're treating the eczema with a topical steroid, and we're treating the depression and anxiety with an SSRI, that we're going to continue to do that, but we're also going to educate the patient and the family on the impact of toxic stress and discuss some evidence-based strategies to mitigate that toxic stress response. And for us, this is kind of what we talk about, which is the stress busters. These are the evidence-based strategies: sleep, nutrition, physical activity, mindfulness, experiencing nature, mental health care, supportive relationships. And I know for many, they may look at this and say everyone should be doing this, or that these are kind of pie in the sky. But I think for me, oftentimes it's really in communication with the patient and the caregiver and making that connection with them about how toxic stress physiology may be driving many of their health conditions and how these are strategies that can be implemented to mitigate the toxic stress response. And so a couple things that I'll point out here is that we have hours and hours and hours of training and guidance on our website and our training site on how providers can implement this. But we have also invested over $65 million in community-based organizations in building their capacity to help implement these with patients and families, and building the connection between primary care screening clinicians and community-based organizations who can support implementation of these activities. And so one other really important piece that often comes up, and I think is in one of the comments, is, whether or not this should be a clinical initiative. And I think this is one of the most important things to answer that question for me, and one of the most important things I believe in the work that we're doing in California. So prior to 2019, children and youth in California, to access specialty mental health, they had to have a diagnosable mental health condition. And in 2019, that changed. And so this is a document that kind of quantifies that change. But in California, starting in 2019, for youth under the age of 21, they can have access to specialty mental health if they are at high risk for toxic stress. So that was really a landmark change here, so that if you're screening for ACEs and you have a positive ACE screen, you have a young person who is identified at high risk of toxic stress, not only can you work on implementing the stress busters, but you can also now get them access to specialty mental health care. And now, in addition to specialty mental health care in California, there are a range of services that are available to children and youth that are high risk of toxic stress. That can be specialty mental health, it could be access to a community health worker, it could be dyadic care, it could be a wellness benefit, and it could be enhanced targeted case management. And when you look at some of the enhanced and targeted case management programs in Medicaid here in California and throughout the country, really, that very often, to gain access to those services as a young person, you have to have already developed a bad outcome. You have to be involved in the youth legal system. You have to be involved in child welfare. You have to have a defined mental health disorder, defined substance use disorder. You have to be experiencing homelessness or a host of other very common negative outcomes that can get you access to care. Here in California, you can get access to those same things through risk of toxic stress. And to what Dr. Burke Harris says, that is an opportunity for early identification and early intervention. And I think for me, kind of before the kids that I take care of now, in their clinical, they haven't been to they don't access their primary care anymore. They've kind of already fallen out of the system. And I think one of our big goals is through the primary care infrastructure, ACE screening is an opportunity to identify these kids who are at risk before they develop the outcomes and get the child and the family access to increase resources and benefits to prevent the development of that bad outcome. And I think what's really important here is how you define toxic stress through ACE screening and markers of toxic stress in the context of Medicaid here in California really influences who may or may not have access to a whole host of benefits and services available through Medicaid. And I think a really important discussion is what that eligibility criteria should look like, and what type of exposures and when those exposures happen to grant eligibility. And I think that's another reason why we hew so closely to using the evidence that's available to ACEs that is tied to poor health outcomes and cost and utilization. And just wanted to, before we end, say that we also recognize that this should not only be a clinical initiative, but that work in every sector and across sector really needs to happen to prevent, identify, and respond to ACEs and toxic stress. And some of the resources that I will leave you with really talk about that. And so this is a QR code to our learning center. We have dozens of hours of CME eligible education and training for clinical providers. This is some of our resources for the clinical response to ACE screening that we share for clinicians around the state. And this is our the California Office of Surgeon General inaugural report, Roadmap to Resilience, that really outlines everything that I talked about today, probably in a much more clear and succinct way than I was able to do. So I think anybody with any questions about our thought process of what we do here in California or why we approach it the way that we do, that this is really the master document that really explains that approach. And I will stop there and pause for any questions.
Thank you, Makai. We have a few minutes for questions because we do have another, we have to, I want to note, Roadmap for Resilience is on the Confluence as a critical resource for this work, and a couple caveats. There are some thoughts in the chat. The great thing is we do have a robust group of ACEs experts, and so some of the same comments we have in the chat, we actually have authors who are part of our SME group who are helping us work through that. Of note, we are conceptualizing toxic stress within ACEs and also other concepts as too. So the other risk factors for toxic stress, the Makai raised, are some of the reason why our SME group is so large. So a lot of the comments that we saw in there are part of the work we'll do going ahead. Any critical salient questions before we move on? Again, Makai, thank you. Dr. Owen, thank you so much. Anything? Okay. I'm going to try, I don't see any, okay, I'm going to try to move to the next section, Questy. We're going to, Asha, are you ready? And I just want to say personally, Makai, I'm a specialist in childhood trauma in my family practice and adolescent trauma, and just thank you.
Thank you.
Because I don't know if I say that part of my job every day, but like, the work that you speak to and the importance of partly why gravity paired ACEs and protective factors together was for this reason, right? Because you cannot do one without the other. We can skip forward to the racism instruments just for the sake of time. But part of why we coupled them is you can't do one without the other, right? You can't identify risk and not lean into fostering protective factors. And this is part of what, I see, I'm not going to call in our friend Alicia, but I see our friend from AFP here. You know this very, very well, right? This is what we do every day in our work with young families and children, and just want to note, thank you so, so much. And I also want to note that even if it's not on the ACEs instrument, many of those concepts that we saw are core to the instruments we use in practice every day, like the Bright Futures instruments, screening for those same things. It's part of what we do in our daily practice. I'm now going to shift the conversation, because part of what we do here, so thank you so much for one of the toxic stress kickoff, Makai, and thanks Dr. Burkeris for coming as well. We're so grateful for you and being part of this work, and there's many more perspectives to come. I'm going to now shift the conversation just to center it, even though I don't probably have enough time. I'm going to hope we can just focus on this. We did have time with our subject matter experts to center and review some of the instruments that focus on identifying person-level experiences of discrimination and racism, specifically focusing on racism as a topic. We heard about themes of this in Makai's presentation. We heard Dr. Burkeris speaking to this as well, right? So this triplet of domains are here by intention. And we're going to talk a little bit in next slide. I think what we want to go first is anyone who's been part of Gravity process before knows that we first try to review standardized instruments. And you heard Dr. Owen speaking to the PEARLS instrument, which is part of what the SMEs are looking at right now. And also other instruments for toxic stress and instruments to identify protective factors, and also identifying instruments to identify person-level experiences of racism was on within our racism subject matter expert group. Next slide. I want to give space, Kwesi, Kenyatta, any of the SMEs who want to speak to these. You can do it better than I, just like we centered Makai. Just raise your hand if you want to take over. The instruments we meet weekly with subject matter experts and discuss instruments and review them. And we only bring to you all instruments that have passed that intentional, thoughtful review. The instruments that that the subject matter experts thought, valid for addressing this domain specifically were these three: everyday discrimination scale, major experiences of discrimination, and the major experience of discrimination abbreviated version. Next slide. We wanted to note that some of the instruments that were approved by the subject matter experts have LOINC encoded questions already because of existing LOINC encoding to uphold research methodology. But there's some questions that are missing, or they need to have SMEs look at them. And there's also opportunities for SMEs to review answer lists. So we don't have those LOINC codes here at this time, but we'll have them back when we come back on in 2 weeks. So the master list for this week represent what concepts are approved by SMEs to date with exact LOINC coding, and then possible more LOINC codes to come. And the following slides just represent the concepts. Next slide. Does anybody, a subject matter expert, want to walk through the everyday discrimination scale? If not, I certainly can. Without seeing a hand raised, I'm going to keep going. Kenyatta was off and on her audio, so I'm going to keep going. Again, please, anyone, take over if you want to. So the everyday discrimination scale asks, in your day-to-day life, how often do any of the following things happen to you? Treated with less courtesy than other people are, less respect than other people are, receiving poor service, people acting as if they think you're not smart, people acting as if they're afraid of you, acting as if they think you're dishonest, acting as if they're better than you are, being called names or insulted, being threatened or harassed. And then the recommended response categories are almost every day, at least once a week. Kenyatta, hi. I would love to center you. Thank you so much.
Hi, Sarah, and hi, everyone. Sarah, thank you for beginning to walk through this scale. I think one thing that'll be useful to share with the group is that just a little bit of background on the scale before we get into some of the detail. These scales were developed by Dr. David Williams. Many of you are probably familiar with Dr. Williams' work. And kind of began with some studies in the Midwest, like the Detroit area study, the National Study of American Life. And so these are seminal measures of discrimination which is which have been used to kind of measure people's everyday experiences of racism. So I just wanted to contextualize, Sarah, that this is a beginning of some of the measurement areas that we're looking at. One set of scales from Dr. Williams with everyday experiences of discrimination. I think that if we were thinking about some of the broader issues like the International Classification of Diagnoses, we'll definitely want to look at some other areas and welcome you all to contribute any thoughts you have on scales. I think these are very contextual to the American setting and probably have been also tested in other settings, but we also want to make sure that we incorporate others. Sarah, I like it if you continue to go ahead and walk through. I
Yeah.
don't think we have to get into the granular, but just high level.
Absolutely. I can do
Thank you.
this.
Thank
Absolutely.
you.
Yeah. One thing that's really important to note that because of specifically leaning into racism, it's important to ask the follow-up question when you have a positive response, because it determines whether it falls into due to ancestry, national organs, gender, race, age, and religion, etc., height, weight, sexual orientation. The reason why this is important is because the specificity was really critical, as determined by the subject matter experts. So just want to note that here. On the next slide as well, we're gonna, there was another, and again, my apologies for like moving through this quickly. I just want to make sure we get to some of the more contextual conversations that are happening next. The next instruments that were, Lucy? Do you have a question?
Thank you, Sarah. Dr. Jackson, I was wondering whether in the previous, this slide, I was wondering whether the administration of this instrument is a factor in the information that results. In other words, if somebody is answering this by themselves on the phone or at a computer, do you find that you tend to get more or better answers than if a stranger, some ancillary person in a doctor's office they've just arrived at, administers this?
That's a good question, Lucy. And I'm going to go, I think you all can look at the instruments on the master list when it's posted tomorrow. I want to go to the next slide and give Cressy the ability to take us home. Next slide, if that's okay. Next slide. Is it okay? Because she's talking about context. Does that sound good, friend?
Mm-hmm.
Okay. I want to, like, the instruments were vetted by the SMEs. They're initial instruments for initial purposes. I would feel remiss if we left today without centering this slide, which is really critical. And so I took us here because, Lucy, your question brought us here. It's really important to note. So we clarified the two types of instruments. We clarified that the answering about the attribution of why is really critical for our work as we focus on racism. As SMEs were discussing instruments, they naturally came to discuss concepts of education and concepts of what accountability to findings looks like, and concept of what happens when you take all that into consideration. And I don't know, Kwesi, if you feel able to kind of pull some of that thought in that we had on Tuesday, given that, Lucy, you raised that here, and it seems like a really appropriate and necessary thing to end on before we, besides talking about the instrument questions and answers in particular. Kwesi?
Mm-hmm. Thank you, Lucy. And first and most importantly, please understand that it may feel like we're rushing at the end of this with something that feels so salient and so important to take time to explore. And I want to just offer that there's no intent to rush. Just sharing and starting a conversation around what we're doing next. Is that cool for everybody? So please do not leave the call with the assumption that as vital of a topic this is, that we are not being careful, considerate throughout the process. That's the first piece I'll offer. Please do not walk away from that. The idea is we're starting and we want to gain some rhythm. Cool with everybody? So please don't look at, Sarah or anybody else in the team like this is so heavy, and now you want us to eat this sandwich without any water to drink after. That's not what's happening. Okay. Lucy, to your point, context is everything. Language matters, and how things are delivered, how things are received are vitally important. We understand that and honor that, and at the same time, we want to ensure that the bi-directional relationships that happen within any context, whether it's provider to patient, direct, vicarious to the community, has context. So we're attempting to start, or we're attempting to begin, is that we want to help the concepts also recognize that at some point in time, there's going to be education to the provider as well as to the patient. Oftentimes we talk about these things as if the provider is the only person that needs some kind of awareness or coaching about what they're receiving. It's also sometimes the patient, and those that are in the clinical space can opine on that sometimes help for the patient to kind of understand what the business happening as well. So I offer that with the 2 minutes that we have kind of remaining, that our hope is that we're creating in some communities, we call this making a cipher, which is a circle of energy that we hold. And in that circle of energy, it grows and it provides opportunity for seeds of growth. That's where we're starting, people. Everybody cool with that?
Sure. And Kwesi, I just wanted to add to Lucy's question. I'm sure that there are some differences in experiences of responding to the scale. We can certainly get into that in some future conversations as we bring more of the literature around the scale to wrap around and talk with you all about it. And I really appreciate your question. So we'll work on a more thorough answer to that question. And for me, it's Miss Lucy. Thank you.
And Mark, addressing your question in the chat, we will make a note in that, put that in the parking lot so we can come back to the car and put some gas in it so that you can drive. We may not have enough time to get to it in the present moment, so thank you. Mark had a question about slides 33 through 35. So we'll get to that.
You might need driver's ed first.
We got a bunch of people here with good driver's ed licenses to teach. This will be a bunch of fun.
Thank you. We are, and again, Kwesi, I really appreciate the fact that you always do such a good job of naming the feelings in the room and the ethics in the room. This is just the beginning. There's a lot more to come, and we thank you for your time. The instruments that we discussed today, as critically important as instruments and foundational, as Kenyatta mentioned, will be the only material on the master lists when they're posted tomorrow at the end of day. And then our subject matter experts are gathering weekly, and we'll be back in 2 weeks with more topics on protective factors, different perspectives on toxic stress, and more work identifying the critical concepts of racism. And we look forward to seeing you in a couple weeks. Thanks for coming.
Thank you.
Thanks so
Thank
much.
you.
Bye.
Thank you.
Thank you.
Thanks, everyone.